Professor Fleischer today is going to talk about hydrolyzed formulas for high-risk infants only or for all infants at risk. Professor Fleischer.
Thank you, Dr. Tam. Thank you. And I want to thank the Hong Kong Institute of Allergy and Nestle for inviting me today. It's really an honor to be here and to speak to everyone. These are my disclosures, which shouldn't have any effect on the study or in the talk today. So there are two objectives. So the first is to discuss should hydrolyzed formulas be used only in high-risk infants who cannot be breastfed, or all infants who cannot be breastfed at risk for allergy. So we'll look at the current data and guidelines, recommendations that support or refute the use of hydrolyzed formula for prevention of allergy in high-risk infants. And the second part will be looking at, are hydrolyzed formulas safe to use in all infants as a standard infant formula? And again, we'll look at the data that support or refute that. So why do we care about allergy and on using and to try to prevent allergy from happening? Well, we know that this is a worldwide public health issue. The rapid rise in all allergic diseases coming in most countries across the globe, both in developing and non-developing countries. So almost 30 to 40% of the world's population has at least one allergic disease. And the increase is really especially challenging in the children who really have the most burden of the allergic diseases over the last several decades. This is just looking at some numbers over the last 15 to 20 years in the United States. And you can see in the red the rapid rise in atopic dermatitis over that time period. And also from the late 1990s, a rise in food allergy to almost 6% based on from the National Health Service in the US. But again, it's not just the United States. This is looking at food allergy in Asia. And you can see a difference depending on what country within Asia you're discussing, where in China, the prevalence may be as high as 4%. In Hong Kong here, about 4.8%. And in Japan can be as high as 10%. And as low numbers in Singapore and Thailand is about 1%. And in my talk tonight, I'll talk more about what specific food allergy differences there are in the different countries as well. And this is just looking at a global survey of food allergy burden in children less than 5 years of age, so preschool, and then older than 5 years of age. So on the left, you can see these are different studies that have been done based on oral food challenge proven food allergy, which is the best, the gold standard of whether you have food allergy or not. Not many prevalent studies actually look at food challenge because it's very difficult to do those in large numbers to get a good prevalence. Some are based on parental reporting and some are just based on symptoms and positive tests. But you can see in the largest study in Australia, the Health Nut study, almost 10% of patients had food allergy, with the highest number being egg allergy in Australia. So what's the importance, and especially looking at hydrolyzed formula and prevention of atopic dermatitis? Well, this is the atopic march or atopic progression we talk about. So in the blue line, eczema. Eczema starting usually first presentation of allergic disease in infants, followed pretty quickly by the development of food allergy with that rapid rise in the first few years of life, and then many patients outgrow their allergies over time, but many of those patients that have food allergy and eczema will go on to develop asthma, and most of them will actually go on to develop allergic rhinitis. So if we can stop the actual development of atopic dermatitis, can we stop the progression and development of other allergic diseases? And this is just looking at the burden of allergic disease if you have atopic dermatitis or not. So in the blue bars, having no eczema whatsoever, and then having in the orange bar eczema, and then the risk of having other allergic disease. And you can see if you've ever had eczema, your risk of having asthma is higher than if you never had eczema. Allergic rhinitis, again, much higher if you have a history of eczema, and then food allergy significantly much higher if you never had a history, if you have a history of eczema. So having eczema within the past year is associated with a significantly higher prevalence of other atopic diseases. We'll quickly just look at what is the definition of high risk, what does it really mean, which infants are at high risk, and really are all infants at high risk. And in my talk tonight, or this evening, I'll talk more about risk factors for allergy and different definitions they use in other studies more recent with looking at timing of introduction of foods. But the typical definition of high risk is either having a parent or a sibling with an allergic condition, which can be any allergic condition, asthma, eczema, allergic rhinitis, or food allergy. If there's no parent with having any allergy, an infant is still at risk of developing allergic disease in about 15% of the cases. If you have one parent that has an allergic disease, that increases to 20–40% chance of that infant having an allergic disease. And if both parents have allergies, then that risk increased to about 60 to 80%. I think when we look at what I'll talk about tonight, the risk is different, I think, really based on genetics. So with my family history, myself, of having asthma still, having had allergic rhinitis and having allergy shots, and having eczema as an infant, my risk is probably much higher for my kids compared to my wife, whether she admits she has allergic rhinitis or not. If she just had mild allergies, would it be the same risk of me having all those other allergic diseases? I don't think those risks are equal. So as preventing allergies, this is the future hope of our field. I think certainly it's a big part of it. It's not going to be the whole picture. We're not going to be ever able to prevent all cases of allergic disease. But looking at hydrolyzed formula and prevention, before the 2000s really was promotion of breastfeeding. And throughout the talk, really, this is if a patient cannot be or an infant cannot be exclusively breastfed, then we talk about using possibly a hydrolyzed formula. Breastfeeding is always going to be the thing that we're going to promote. In 2000, though, at least in the American Academy of Pediatrics in the United States, again said breastfeeding is optimal, but in those breastfed infants who can't be exclusively breastfed for the first 4 to 6 months of life, are actually considering using, actually avoiding foods in a mother's diet, highly allergenic foods, to prevent allergy from happening, and actually infants avoiding certain foods for a certain period of time to try to prevent allergy from happening. In 2008, they really said you don't have to avoid those foods, but if you can't be exclusively breastfed for the first 4 to 6 months of life, there is some modest evidence, and we'll go through some of that, that using a hydrolyzed formula can actually prevent the development of atopic dermatitis and possibly milk allergy as well. And then in 2013, again, we said for infants at increased risk of allergic diseases, if you can't be exclusively breastfed, using a hydrolyzed formula appears to offer some benefit. And again, we'll go through some of those studies. Again, breastfeeding is going to be the most important. We're not going to use the formula over breastfeeding if someone can be exclusively breastfed. But this is looking at the risk factors of developing allergic disease with the risk of allergic disease, risk of 1. Breastfeeding can reduce that risk and certainly has a role in prevention over using an intact cow's milk formula. And we'll look at some of the hydrolyzed formula data too. Again, does it reduce the risk of allergy? And this is looking at atopic dermatitis prevention and breastfeeding. Again, you see a relative risk reduction with patients that are exclusively breastfed compared to using a standard formula. So can the risk of allergies be reduced in non-exclusively breastfed infants? So it really depends on what studies you look at, what meta-analyses you look at, and I'll go through some of the different societies' recommendations depending on how they look at these studies. But this is looking at some of the studies comparing the risk of atopic dermatitis under 12 months of age by using a partially hydrolyzed formula versus a cow's milk formula, again, in infants that cannot be exclusively breastfed for those first 4 to 6 months. And you can see on the left side, there are some studies that had statistical significance. If you use a partially hydrolyzed formula, a whey formula, that you could decrease significantly the risk of atopic dermatitis in the first year of life. But even the ones that didn't have statistical significance, you can still see that there is some benefit in preventing atopic dermatitis in these studies. Probably one of the most quoted one is the GENIE study, or the German Infant Nutrition Intervention Study. The results shown here are out to 10 years. It actually showed this actually continues to have some effect out to 15 years of age. But this looked at about 1,000 infants randomized to formula supplementation if they weren't exclusively breastfed to either a cow's milk formula or one of 3 hydrolyzed formulas. 2 extensively hydrolyzed formulas, 1 whey and 1 casein, and then the 1 partially hydrolyzed whey formula within the first 4 months of life. And then they looked at follow-up out to 10 to 15 years, looking at ISAC questionnaires, looking for allergic disease. What they found is you can see that the partially hydrolyzed whey formula and extensive hydrolyzed casein formula had significant decreased risk of developing atopic dermatitis compared to the cow's milk formula. Most of this effect is probably within the first 4 years of this, but there was a maintenance of effect, as I said, out to 10 years and even out to 15 years. One caveat here is that this was the per protocol analysis, which is a little bit weaker evidence compared to the intention to treat analysis, but you can still see there was significant effect. The other important point is it didn't have any effect on other downstream allergic diseases. So while it may have prevented atopic dermatitis, it didn't have effect on asthma, allergic rhinitis, or other allergic sensitizations. And again, as I said, looking at different meta-analyses, this is one looking at the studies of superior methodology, looking at partially hydrolyzed whey formula versus a cow's milk formula and the risk of atopic dermatitis. And you can see, even though some of these studies I showed you in the first figure didn't reach statistical significance, overall, there was a 55% risk of reduction of atopic dermatitis looking at these 4 studies. And these are just different meta-analyses that have been done. The one on the left is a meta-analysis done by Bob Boyle out of the United Kingdom. That was published in the British Medical Journal just last year. On the one on the right, I'm still going to present it. It's the Cochrane reanalysis of data. I want you to just note that it was submitted back for publication in May, but it was withdrawn due to a data entry error, so this will be reanalyzed. But I think it's still important to show the contrast between different meta-analyses and how you can get different results. So again, in the Boyle paper, this is looking at randomized controlled trials using a partially hydrolyzed formula or extensively hydrolyzed formula compared to a cow's milk formula and any allergic sensitization to cow's milk. In their studies, when they did the meta-analysis, they didn't see any significant difference in the risk of any food allergy reduction, including cow's milk allergy. But depending on what studies you look at in your meta-analyses, in the meta-analysis, again, the Cochrane, with the caveat that it was withdrawn, they did see within 2 studies a significant risk of reduction in cow's milk allergy by using a hydrolyzed formula compared to a cow's milk formula. This is again looking at the Boyle study on the left and then the Cochrane study on the right. Looking now at eczema or other allergic disease up to 4 years of age in the Boyle paper versus up to 2 years of age, so different analysis in the Cochrane. And you can see they didn't find any statistical significance in the British Medical Journal, the Boyle paper, but again, I think we get focused on really confidence intervals, and if it crosses that magic number of 1, that it really is not statistically significant, but does that really mean that there isn't any benefit from having used a hydrolyzed formula? And you can see that it's not that high above 1, so 1.07 and 1.17. So you can argue, even in the Boyle meta-analysis paper where they looked at all hydrolyzed formulas, there likely still was benefit, although they don't state it because, again, it crossed that magic number of confidence interval of 1. But in the Cochrane paper, you can see that while eczema up to age 2 years in 9 studies that they used didn't show an effect, again, you still see very close to 1.01. So I think still you can say there's some benefit. Any allergy up to 2 years of age, again, they did see it, but again, you have to take the caveat that there was some data entry error. We don't know what that 1 point is, but they will reanalyze it. But I think, again, the important point is what is the role of breastfeeding in some of these patients in some of these studies as well? Because you cannot randomize patients to breastfeed or not breastfeed. It's not ethical, obviously, to do that. So I think partial breastfeeding probably likely plays some role, but I think, again, we're looking at hydrolyzed formula. And there's strikingly similar situations in what the final conclusions were from both meta-analyses. There's no evidence, again, to support feeding with a hydrolyzed formula compared to breastfeeding. So again, breastfeeding is always going to be what should be promoted. But if you can't breastfeed, should you use a hydrolyzed formula? And the Boyle analysis, meta-analysis, and systematic review, they did not find any significance. But again, I think it was so close to one you could argue there's probably some benefit if you're not going to be exclusively breastfed. But with both meta-analyses, I think the hard part is there was significant bias in these studies and conflict of interest. So the bottom line is we do need more future trials that are prospective, registered, independently funded, and include adequate oversight to ensure that they do not negatively impact breastfeeding. And you'll see, again, similar thing with the Cochrane analysis. No evidence to support using a hydrolyzed formula over breastfeeding for prevention. And again, we need more large, high-quality studies to actually determine whether this usually really works or not in patients that can't be exclusively breastfed. So what are the expert statements from our different societies around the globe? So the Quad AI is our major allergy academy in the United States. And back in the paper that I did in 2013, based on the evidence at that point, we really felt that, again, for infants who are increased risk of allergic disease, based on the high-risk criteria of having a family history, parent or sibling with allergic disease, for the first 4 to 6 months of life, if you can't be breastfed, using a hydrolyzed formula, it appears to have some benefit. Then NIAID, which is the National Institutes of Health part of our, in the US, also felt the same back in 2010, that they consider the use of a hydrolyzed formula if you can't be explicitly breastfed over using a standard cow's milk formula. The American Academy of Pediatrics, as I also showed back in the slide in 2008, said essentially the same thing. EFSAGAM, which is the European GI group, again, in high-risk infants when breastfeeding is not possible, hydrolysates of documented safety and efficacy seem to have an indication in infant feeding for the up to 4 to 6 months if you can't be exclusively breastfed. YACI, which is a European allergy, says a similar thing. Again, using a hypoallergenic formula may have some benefit over a standard infant formula. Really, the big difference that we see is with the ASCIA, which is the Australasian Society of Allergy and Immunology, which based just on the Boyle paper essentially reversed what they had said in their guidelines, and really the only one that says there's no consistent, convincing evidence to support a protective role for partially hydrolyzed formulas or extensively hydrolyzed formulas if you can't be exclusively breastfed. I'll argue, and we're rewriting our guidelines now for the United States, which will be published next year. And I'll give you my personal opinion. Again, I think if you can't be exclusively breastfed, I think there is some, there's certainly no harm, and there may be some benefit for using a hydrolyzed formula for prevention. And again, the Hong Kong Institute of Allergy and their guidelines published just last year also say consider hydrolyzed formula milk in high-risk infants if exclusive breastfeeding is not possible. So I think the majority of societies will say it's safe and may have some benefit, whereas again, depending on what society you look at and what meta-analysis you look at, may argue or refute that. So conclusions, allergic diseases, for this first part, conclusions are an increasing global health problem. Depending again on the meta-analysis in medical society, data and societal recommendations are conflicting regarding the use of hydrolyzed formula for the prevention of allergy in high-risk infants who are not exclusively breastfed. But I argue while there's supporting data may be limited and the quality of the data may be low, using hydrolyzed formula in a high-risk infant who cannot be exclusively breastfed may provide some benefit, and there may be no health risks or increased costs depending on the formula and the country where those formulas are. So, but again, additional large, high-quality studies are going to be needed to continue to show with convincing evidence that this is the case. So the second part and last part of the talk, looking at hydrolyzed formulas. Are they safe for all infants? Infant formulas, again, looking at the guiding principles for their use. They should only be used when medically indicated and or when exclusive breastfeeding cannot be possible, and should primarily seek to provide evidence-based functional benefits which minimize the complications that result from not exclusively breastfeeding. So what does it look like when we look at the growth of patients that are infants that are on infant hydrolyzed formulas compared to breast milk? It's hard to see in the gray, but the gray bar is in here. But you can see with hydrolyzed formulas there may be a little bit more of a dip within those first few weeks of life or months of life in their weight, but again they catch up pretty close to being consistent with other formulas and with breast milk. So again, feeding with a hydrolyzed formula, this is based on the Gini results, did lead to a transient lower weight gain in the first year of life, but no long-term consequences or different formulas on BMI were observed. And hydrolyzed products with casein may have a lower biological value with a lower nitrogen and higher urinary amino acid concentration, but again, what that really means on the effect of the infant, we don't really know, and I don't think there's any harm even based on those. Looking at whey protein compared to casein, whey proteins contain all the essential amino acids needed for growth. They may be higher in high branch chain amino acids and in cysteine. There's some theoretical concern that it may have some effect on absorption and utilization of partially hydrolyzed protein compared to intact protein, but again, I think based on decades of using these formulas, we don't see those effects. And while there is insufficient data to conclude whether digestion and absorption of a partially hydrolyzed formula compared to a standard infant formula or breast milk provide similar levels of bread metabolites, initiate similar hormonal responses, again, I don't think we see the harmful effects of using any hydrolyzed formula. What about some other physiological properties of formulas compared to breast milk, such as gastric emptying? Here you'll see gastric emptying times compared to breast milk in partially hydrolyzed whey is pretty exactly the same as in breast milk, whereas intact whey and intact casein dominant may have a lower effect on gastric emptying. And what that really means is that in preterm infants you may have some benefit in using a hydrolyzed formula for quicker gastric emptying compared to term. What about gastric emptying with respect to the curds and whey? So curds are what we call clotted casein proteins, proteins that require further breakdown, mechanical and chemical digestion before leaving the stomach, but 100% whey protein forms no curds and may empty faster. So again, in preterm infants, you may have some benefit in actually using a hydrolyzed protein that contains whey proteins. Stool consistency is something they also look at when you start comparing different hydrolyzed formulas to breast milk. And whey proteins formulas tend to lead more, based on some studies, to softer stools. And hydrolyzed proteins, again, comparing to breast milk, seem to be quite similar. They're easier to pass, less discomfort, so they may have some benefit in all infants compared to other hydrolyzed formulas. But again, based on limited general available literature, partially hydrolyzed proteins tend to have some benefit on a functional GI symptoms such as stool consistency and gastric emptying, but the evidence is really not sufficient at this point to make a formal recommendation. What about cost benefits? So anytime we use a formula, we want to make sure that we're not increasing the cost to families. You want to have some cost-benefit ratio that favors whatever formula you're using. So this is looking at one study, and there's multiple studies done in multiple countries, but this is looking at the economic impact of using risk reduction in the first 6 years of life using a partially hydrolyzed whey protein formula compared to a cow's milk and what the cost benefit is. This was a mathematical model, so this is based on the Genie study and developing market data and expert opinion. And the key outcomes were looking at atopic dermatitis risk, time with post-atopic dermatitis diagnosis and symptom-free days without atopic dermatitis. And what they found in this mathematical model was you do have significant, based on if you impute the Genie results, that you can significantly reduce the risk of atopic dermatitis from 38% down to 24% by using a partially hydrolyzed whey formula. And you gain about 40 days, a little over a month, of symptom-free days without atopic dermatitis and save about $500 per month if the cost of the hydrolyzed formula, whey protein, is similar to a standard infant formula, which in the US and some countries it is. And when they look at that, in the US, there's about 4 million infants born every single year. About half are actually not exclusively breastfed, and 31% are born to what we call high risk, again, families based on the family history of allergic disease. And the savings of those with high risk was about $350 million based on this model. And even the ones without a family risk of atopic disease, again, because we have patients, even though they don't have a family risk of atopic disease, are still, many of those will develop allergy. There was savings almost $400 million. So in this mathematical model, you save almost $750 million a year, which doesn't account for any possible downstream effects of not developing food allergy, not developing allergic rhinitis or asthma. So could hydrolyzed formulas be considered for routine use in any infant who cannot be breastfed? And we'll go through the pro-con of these in the table. From a regulatory standpoint, for the US, European, and Canadian agencies, hydrolyzed formulas do meet all nutrient requirements of standard infant formulas. For metabolism, absorption, gastric emptying, again, I went through some of those things. There are no formal recommendations on those, but the metabolic consequences and long-term data show that gastric emptying and absorption don't seem to be affected. Again, we have decades of experience using these, and we don't seem to have any adverse outcomes by using hydrolyzed formulas. Gut maturation, and Mimi Tang will talk some about the gut and the microbiome later, really don't have, again, sufficient evidence to say that they're going to have different effects on the gut microbiome. So really, for these four, metabolism, absorption, gastric emptying, and gut maturation, we really need more long-term studies. But again, I think we've got enough data to show that it's not dangerous using these. As far as allergy prevention, which is, I guess, one of the more controversial, first one's based, again, on what society recommendation you use or what hydrolyzed formula, what meta-analysis you use. If breastfeeding is not sufficient, I still feel comfortable saying, and we'll stay in our guidelines, again, that will be published next year in the US, that if you can't exclusively breastfeed for the first 4 to 6 months of life, the use of a hydrolyzed formula really may benefit in reducing atopic dermatitis, and whether or not that works for cow's milk allergy as well. But I think there's enough evidence to say that if you can't do it, they're safe to use, and it may actually benefit. Organoleptics is a fancy term for what does it taste, how well does it taste, and the hydrolyzed formula, partially whey, does tend to taste better than other broken down proteins, essentially hydrolyzed proteins. Again, the history of safe use, we have decades. So cost effectiveness, it does seem to have some cost reduction depending if you can, how much atopic dermatitis you can reduce. So overall, the scorecard, I would say the number of pros seem to outweigh the number of cons in using a hydrolyzed formula in patients that can't be exclusively breastfed in all infants. In the last 2 slides we'll look at, I want to distinguish the use of hydrolyzed formulas for prevention from actually using them to treat an allergic condition, and those things are quite different. So if you have a term infant, that exclusive breastfeeding, again, is what's going to be recommended for all infants for 4 to 6 months. If you can't exclusively breastfeed, we'll go down that arm, and then looking at if you can exclusively breastfeed for 4 to 6 months, then the timing of introduction to complementary foods, which I'll talk about later tonight, and we'll go through the timing of specific allergens. They're recommended now at 4 to 6 months of age. If you have a family history of allergy, for prevention, you can consider using a partially hydrolyzed formula or essentially hydrolyzed formula. If you don't have family history, you can, again, consider using a hydrolyzed formula because, again, some of those infants are likely at risk for developing allergy versus a standard formula. And then whether or not you have a family history of allergy or not, if a infant has atopic dermatitis or has a documented food allergy, for treatment of those diseases, using a partially hydrolyzed formula is not recommended. You need at least extensively hydrolyzed, depending on, some patients need amino acid formula, but again, a partially hydrolyzed formula, if you've got atopic dermatitis or possibly food allergy, won't work and is not recommended. Using a hydrolyzed formula, extensively hydrolyzed formula, is recommended. So final conclusions. Due to a paucity of data, the routine use of a hydrolyzed formula as equivalent option to breastfeeding or our standard infant formula cannot be supported presently based on available scientific evidence. However, prior use of hydrolyzed formulas over many decades has not identified any safety concerns, and I think the benefits, again, the pros outweigh any potential risks and the cons. Again, though, long-term studies are needed to investigate the feasibility of a hydrolyzed formula as a routine feeding option for healthy standard risk infants.